one of the clinical editors for Health Pathways in Cardiff and Vale. I also work collaboratively with the other health boards to develop clinical pathways for primary care, and I'm really delighted to have two speakers with us today. We've got Dr. Claire Tibbats, who's a consultant gastroenterologist and leads the IBD Implementation Network in an Iron Bevan Health Board, and Dr. Amal Wahid, who's a consultant paediatric gastroenterologist. Today's session will hopefully be really informative for everybody, and just a special thanks to the RCGP as well and Kate for organising this session and giving us all the support to make this session happen. It's really important for us in primary care to keep up to date and also know what's happening in the world of gastroenterology. So this is a really exciting opportunity today to go through the latest guidance and updates. So I'll talk briefly about health pathways and how we are implementing the guidance through the health pathway system, and then we'll have a talk from Claire about adult IBD and the fecal calprotection pathway, followed by a talk by Ammar on paediatric IBD, and then hopefully after that we'll have some questions and answer sessions. And I guess this is a really good bit. We've got two specialists in the room today, so ask away, ask any question. No question is a silly question, and this will help us all in our learning. We hope to finish by 8:30. We might finish before then, but that's the general plan for today. As we said, this is being recorded, and question and answers. If you put your questions in the chat bar, I'll read those out at the end, and then we'll email out your certificates at the end. It'd be really helpful if you could provide the feedback for us. So a little bit about the Health Pathways programme. So we've been over 5 years since launch in Cardiff, and what Health Pathways is primary care guidance, which is where we work with local specialists to develop our local guidance. This is growing, and now it's becoming an All Wales programme, and we've been really lucky enough to work with the IBD team to try to produce guidance where it should be the same across Wales, ideally. And so I've been working with Claire in sort of documenting this process for us. In the background, the hospital health pathways has also taken off in Cardiff, and what we're hoping is that there'll be a seamless continuum from primary care into the hospital health pathways. Now, it's the health pathway for IBD is currently live in Cardiff, and the other areas within Wales which it's currently where Health Pathways has a programme is in Hywel Dda, CTN, ABHB, and SBUHB, but Betsy Cadwaladr is coming on soon. So the work we're going to go, all the work we've done for this programme will be available across all the health boards to put into practice in the next couple of months. This is the login for the Cardiff site. So if you work within Cardiff or you locum within Cardiff, you're more than welcome to use our Cardiff and Vale Health Pathways site. The QR code is there. Username and password is Health Pathways with capital H and capital P. Health Pathways can be accessed on your phone, on your mobile, at work, and it links to all our primary care guidance. And who's Health Pathways for? It's for anybody within primary care. It could be your GPs, it could be your nurses, but we also have important other aspects which might be helpful for your receptionist staff as well, and care navigators. So I'll just show you that quickly as well. And I use Health Pathways a lot during my consultations. We use it for learning and CPD, but it's useful to know because this content is localized, who to contact and who to contact, where to contact them. So these are our top pages for Health Pathway hits, and I've checked earlier, and we're around 1,700 hits a month Cardiff just for the gastro pages. So they are really used within general practice in Cardiff and Vale. So if we go back to the beginning bit of IBD and how patients might interact with us in primary care, what you might find help with your care navigators is the home page. So if you click on the care navigation page, it has the contact details for usually the specialist teams where they have a specialist nurse. So for example, in Cardiff, there's an IBD specialist nurse who you can ring. There's a number for patients to ring. So if reception are not sure and they say, oh, I've got a patient with IBD, they need to get in contact with them, they can click on that care navigation page and the receptionist can give them the advice of the number of the local guidance where to ring. It doesn't stop patients from accessing us, but it gives an additional layer of safety. And this is what a typical health pathway looks like. I'm not going to go into the pathway itself because I'll put a link in the chat bar for you to have a look at yourself in bigger detail. But all the health pathways have a similar format. They have the red flags, which are things which are commonly missed and not to ignore. We have some background information about some basic facts about inflammatory bowel disease. But most importantly is things like assessment and how can we assess our patients in primary care safely. Now, the important things with these pathways is that they follow quite a strict governance process. So everything from prescribing is looked at, and the LMC are also involved as well. So it gives you the confidence that everything we do is not looking at a shift of work, but trying to enhance the work we're already doing. But also what to consider if a patient presents with symptoms which could be IBD. We also cover things such as risk factors and immunization and contraception. So all the other things which we have to consider when we see patients who have IBD. Within the pathway then, we also have how we might assess a patient, what tests you may or may not do, depending on the urgency, and then as well as how to get advice. So who do you refer to if they have certain symptoms? How can you get advice? So for example, in Cardiff, you can use Consult and Connect if you need to speak to an IBD specialist. And also, we also consider the out of hours period as well, and how can we manage these patients who present at out of hours. So we take care of all these different aspects with a primary care lens, so that it helps us in primary care that support our patients with IBD or who have established IBD. Also, the calprotection pathway is going live soon, the new updated guidance, and that will be live probably in Cardiff in the next 2 weeks, and then across the other health board over the next couple of months. And in the same way that we have, it gives us our snapshot information and access to the guidance for how to interpret calprotection tests and when we should be doing them. So that's a quick overview of the health pathway system. And if you have any questions about that, please leave a message for me in the chat bar. When the slides go out after the meeting, I'll also include the usernames and passwords for the other health boards. So if you work in Betsy or Clontarf, you'll be able to access your local pathway that way. Thank you very much. I'll pass you over to Claire.
Can you see that now?
Yeah.
Am I sharing the right screen? Brilliant. So thanks for this opportunity to speak to everyone tonight. Here we go. So who are we? So we're part of the NHS exec, which has been going for a couple of years now, but the IBD Implementation Network was only started in April of last year, so we've just turned 1. And what we were asked to do was to reduce variation in IBD care across Wales and to improve the overall standard. So what we've done in order to do that is we've started off with a baseline assessment that some people on this call may have been involved with. And we've used the IBD standards and sent out a questionnaire to every health board across Wales. And then we've benchmarked them against the standards. And we've produced this All Wales IBD report, which shows the position where we are now. And we've also got the individual health board reports, which shows their individual position compared to Wales, and an action plan about how we can improve these things. If anybody wants them, these will be on the IBD website that we'll share later, or we're happy to share them. And it's just gone through the National Clinical Framework. And I believe the emails have gone out today. So this has now been issued to every CEO and medical director of each health board with their position and the action plan of what we need to do to improve IBD care across Wales. So there's going to be some real accountability going forward. So these are the standards. I'm sure most people are aware of these. There's 59 of them. They're currently being updated, and I'm on the board for that. And I think it's due to finish around about July. There's not going to be massive changes, but just some of the deadlines and the timeframes and things are going to be updated. And some of them are very specific, giving sort of timeframes of when tests should be done. And some of them are a bit more general, saying you should have protocols and you should have teams in place. And they're split up into the 7 different stages that you can see there. We're also about to have BSG guidance updated on IBD prescribing and IBD endoscopy surveillance. So they're due sometime in the next month or so. So what does it show? There's an IBD dashboard that anybody in healthcare can apply to have access to. And it shows everybody's performance, both their individual and the All Wales position. And you can amend it in whichever way you want, by patient stage or by STEEP, which is the Welsh Government process and how they like to look at results. So what it shows, as you can see, there's that everyone's working quite safely and effectively, as in we've got teams, we've got named consultants, but we're not doing quite so well on the equity. There's definitely pockets in Wales that are really struggling, and the patient-centred care could do better. As expected, timeliness and efficiency is the worst performance, because everyone is basically firefighting in every IBD service across Wales. People aren't getting their endoscopy in a timely manner. They're not getting their clinics in a timely manner. So this is just a snapshot of where we are as of right now, and also what we want to do. As this is updated on a 6-monthly basis, you'll be able to see on the dashboard the progress and the change. So we'll be able to track improvement or lack thereof and hold people to account for this. So this is another RAG rating that you'll be able to see on the dashboard. So this is the timely standards. So these are the ones that say how quickly you should have your endoscopy, you should have your clinic, you should have reports to the GP. And as you can see, we're failing on pretty much all of them. And timeliness will be one of the last things to recover, because nobody meets the workforce standards. There's lots of protocols and inefficiencies that need to be updated. And once all that is in place, then your timeliness is going to follow. But we've got a 10-year plan. This is not going to change overnight, but we're hoping to see some immediate improvement over the next year or two, working towards every health board in Wales meeting the IBD standards within about 5 to 10 years. Some of this is outside of our control. Things like endoscopy sit with diagnostics and the National Endoscopy Programme, but we're contributing when it comes to the IBD side of endoscopy. So what we've tried to do, one of the important things that we've tried to do is raising the profile of IBD, because it's surprising how many people who are in power making decisions don't actually know what IBD is. We often get the comment, oh, it's just a bit of diarrhea, isn't it? So we've tried to describe what IBD is to non-medics, and this is what we came up with, how it's a cycle of relapses and remissions, and how you can never discharge a patient because they're always going to have IBD and they're always going to need to be in the service. And we've hopefully tried to demonstrate to them here how you need joined up care right the way from primary, secondary through to tertiary care, and just how many different specialties are involved in managing these patients. It's a true multidisciplinary disease. It's not just confined to your bowel. It has all the extraintestinal manifestations. And even if we get you into remission, you still need monitoring and surveillance. And then there are always a proportion of the patients who are going to flare again and start the cycle and need to go back through. So this is just trying to really illustrate to the powers that be just how difficult it is balancing, immunosuppression enough to keep the disease under control, but keeping the patient well and balancing all the different systems between them. We've also looked at the patient pathway. So right from when a patient starts experiencing and reporting symptoms all the way through to getting them in remission and surveillance. And these are just some of the innovations that are going on at the moment. And we all know talking about bottoms and stool is not a popular topic for people, particularly men and particularly young people. Teenagers don't want to be talking about their bowels or stomas. So it's trying to raise awareness and trying to get these discussions out in the open, making sure that patients are presenting to the GP. So it's right the way from working with public awareness campaigns, trying to get through the digital transformation, which is massive, because for any chronic illness, you don't want to be relying on paper. You don't want people having to be going back to their GPs. You want them to be able to access their specialist opinions without having to go through a really slow paper process. So we're looking at digital transformation and apps, and then being able to get their blood results and being able to get emails. And we're working on all those sorts of things to speed up the pathway and maybe take some parts of the pathway out so the patient gets diagnosed and treated quicker, and we make everything much more efficient. The focus today is on the blue bit, the bit in primary care, the front end, getting patients to present and what to do with them and how to get them through. So this is what we've done. We've written a calprotectin pathway, and we've combined the paediatric and adult into one, so it's all in one place. And this starts from Barney's old pathway, from the old CLAB, and we've taken it through the full process. So it's gone through our clinical reference group, and that has got a representative from every single health board, so they're all represented. We've got every single member of the MDT right the way through from primary care to surgery to pathology. And once it's been presented and agreed by the clinical reference group, it's then gone out for wider consultation. So it has gone to the AMDs for primary care in each health board, and we've now got a nominated primary care AMD to work with us in gastro and IBD going forward, which should hopefully make things a lot easier, because we're a new network. We've now got the contacts that we can use to disseminate this a bit easier. It will be, this is the dashboard, this is the website that will be live in the next few weeks. We'll share the links for this as well, but when it's live, there's going to have two different bits. One for the patients. So when you've got patients with IBD and they've got lots of questions, they just click on the patient bit and it'll take them into their section, and that's accessible by anyone. It's going to have different sections, information about psychology and well-being, about medication, about self-help, all that kind of thing. And then there's the section for healthcare providers, so where all the policies such as this is going to be in there, any updates, any research, any contacts, anything you need, and that will be accessible by people who have an NHS website. So that should hopefully be going live sometime in the next few weeks. So to calprotectin, what is it? It's a protein that's released into the gut when it's inflamed. And I think one of the misconceptions about calprotectin is that it's diagnostic of IBD. So it's just to clarify that it's not. It's a marker of inflammation, and anything that causes inflammation can make your calprotectin to go up. It's a very stable protein, so it can be detected in your stool, and it is NICE approved for these reasons. So the reason we use it, we all get lots of people with lower GI symptoms, and we know that research shows that GI symptoms are not a good indicator of whether somebody has pathology or not. So the reason to use it is to try and get the patients who do have pathology into their investigations, that get them diagnosed and get them treated quicker, and also not to over-investigate the patients who don't need it, the patients with IBS who can be managed elsewhere. And I've used in the GP Health Pathways in Cardiff for some years now, and it's really, really helpful. And I think it empowers people to be able to manage them without doing the unnecessary investigations, because you can say you refer to GP Health Pathways, and I know some patients like a test for reassurance, so being able to do a calpro and tell them that it's normal is often really helpful. And we want to reduce the delay in those patients who do have the disease in getting their diagnosis, and that's the NICE guidance there if anybody wants to read it. So something to help clarify that would be really useful is the appropriate use of calprotectin. So one thing we look at is the clinical history. It's not to be used in acute diarrhea of under 4 weeks, because most of the people who've got an acute diarrhea will have an abnormal calprotectin anyway, because it's usually infective. There's a list of the things in the table there that will raise your calprotectin apart from IBD. So if anybody's got known diverticulitis or anybody's got known Campylobacter, and they've got a raised calprotectin, you don't then need to investigate them for IBD. That's a really common scenario where maybe they've been sent into the surgeons and a surgical house surgeon has done calprotectin, but they've diagnosed them with diverticulitis, and then we'll get a referral saying, does the raised calprotectin mean they've got IBD as well? The answer is no. If you've got something that causes raised calprotectin, you don't need to investigate unless you're suspicious that that they've got IBD as well. And we've now got FIT as of last year. So in patients over 50, really they're more likely to have cancer, or you need to rule out a cancer. So use FIT in the patients over 50, but also in younger people, if you think they've got symptoms suggestive of cancer, don't be afraid to use FIT or do both. That's not a problem. And make sure that people haven't been on NSAIDs within the last 4 weeks, because it's automatically going to be positive. So it's not really a very helpful test. These ones up here, the diverticulitis, appendicitis, these usually give a reasonable rise in your calprotectin. There's ones down the bottom here, smoking usually gives those borderline results, slightly positive. So just a quick mention about the assays. I've learned a lot about this recently. I didn't realise Cardiff used a different assay to the rest of the country. These are what the comments currently say and what the ranges currently say. The good news is that Cardiff will be changing to the same assay as the rest of Wales, but they've got to wait for the LIMS update. So we're told it's going to be round about September-ish, but then we're going to have one assay across the whole of Wales. And they're updated in Welsh Clinical Portal, and the comments, we're told it's going to be done round about mid-May. So that's the target at the moment. So there was lots of discussions about what we should make the range be when we use the same range. Initially, they thought the difference was only about 10-20%, but they think the difference between assays now probably more about 30-40%. So there was lots of discussions between some very clever microbiologists and biochemists, and they've suggested the new range, and they've done comparisons of both the assays, the new and the old, and they've come up with the suggestions for us. And we've also looked at the other pathways, things like the York pathway, which uses the CalTurbo assay, and we've aligned. But if you look at the research, there's no clear cutoff. The lower range can be anywhere between 50 to 150, and the top range anywhere between 200 and 250. So it's been recommended to us, the new range, but we are going to look at our results after 6 months and see if we need to adapt it and do some more comparisons. So it's a work in progress. And I didn't realise you can get different levels from the same sample depending on which bit of the stool you test. So they take at least 3 samples from one stool and get an average. So interpreting the results, just a few caveats. As with anything, it's not a perfect test. A third of your patients that will have a raised calprotectin will just have IBS, and a third of your patients, if you repeat it again in 4 to 6 weeks, will normalise, and again they have a functional disease or IBS or a self-limiting infection. And also you can have a proportion of patients who do have IBD and have a normal calprotectin as well. So if you're really concerned, please do just write that in your referral. So this is what the new reference ranges are going to be, as suggested by biochemistry. Below 100 is going to be normal, above 250 is positive, and then there's that grey area in between 100 and 250. And some of the feedback we had is that some of the health boards have had to fill out annoying other forms saying there's no PR bleeding and I'm not a robot and all that sort of stuff. So I'm told that with the LIMS update, that's all gone. So it's going to be available on Welsh Clinical Portal. It's just a button that you click and you won't have to fill out any other forms. The only thing you're going to have to do is say whether it's for diagnosis or monitoring. And in primary care, it's pretty much always going to be diagnosis, and generally be secondary care that monitor the response to treatment with the calpro. So just let you know, in an Arran Bevan, the only health board to have a calprotectin nurse. So currently every positive calprotectin that is referred in from primary care goes to the calprotectin nurse, who arranges what to do with them. So I've got the data from last year, and we had a look through, and it was really reassuring, and they had nearly 500 patients. And of the patients who had an eventual diagnosis of IBD, none of them had a calprotectin under 150. And that's with the new assay that we're going to use. We then looked at the intermediate group and what happened to them, and pretty much all of them ended up going to clinic and then having a colonoscopy, which were then all normal. And the weights ranged from a few months to over a year in some cases. So that's a massive waste of resource that the patients are waiting a year just to be told they then need to have a colon, which is then told that it's normal. So it's trying to manage the unnecessary investigation in these patients as well. There was only one patient who had a colorectal cancer under the age of 50, and his calpro was positive, and he also had a FIT because he had other symptoms suggestive of cancer, and he was diagnosed in a 2-week wait colonoscopy. So we then looked at, if we took that data from last year and applied the new range, what would happen? And so if we applied the new 100 to 250, you'd get almost 30% could be managed via the GP health pathways and managed in primary care and not have an unnecessary colonoscopy. Of the 44% who had calpros of over 250, they would have gone straight to urgent colonoscopy, cutting down your waiting time. Because as we said, some of those patients were waiting up to 18 months to get their clinic and then get their colonoscopy. So of those patients who did have IBD, their waiting time would have been cut down from 18 months to roughly 2 or 3 months with an urgent colonoscopy. When we did look at that cohort of patients who had a positive FIT, a further almost 20% had acute symptoms whose calprotectin normalized on repeat testing. So again, it's just to make aware that the history is really important, because some of those patients would have gone straight to testing, had an unnecessary colon because it was done when you had patients with positive Campylobacter and things like that. So what is the pathway? There will be a link. I know it's a bit small. There's nothing controversial in this. It basically says if they've got symptoms of IBD for longer than 4 weeks, please send a calprotectin. And then there's the wonderful GP health pathways that Kurma has described to have a look through. Can they have the basic diarrheal screen and make sure they haven't got NSAIDs or any other diagnosis like diverticulitis or a known infection before you send it in? They're under 16, you follow the paediatric pathway. If they're over 50, use your FIT pathway. So it's those young adults in between 16 and 50 that will go through this pathway. If it's normal, less than 100, they can be managed by the GP health pathways. If it's intermediate, then they need to be repeated after 4 weeks if the symptoms persist. If the symptoms go away, you don't need to repeat it. It's just going to normalize. But if the symptoms persist, do it again. And then if it's intermediate or high, refer in to us. And then what we do with that, depending on the intermediate or high second result, they will then either go straight to test colonoscopy, or in an Iron Bevan, we're piloting a scheme where the calprotectin nurse is now going to have an urgent triage clinic, where if it's appropriate, they'll send them off straight to colonoscopy, or if not, they'll do the other investigations and see them as a nurse-led clinic to try and get them through the system quicker rather than having to wait a year or so for a general gastro appointment. And all of this is designed to reassure and enable the GPs, empower them to manage the patients in primary care that can be managed there, but also to get the patients who need to be seen, get their diagnosis quicker, get them through the system quicker. So that's our email in the IBD network, and this is the link to the website. I think we're going to share all of these in the feedback forms, and there's the code directly to the pathway. And I believe Kurum's put in the pathway on GP Health Pathway sometime in the next week as well. Thank you.
Thank you, Claire. That was really, really useful. I'll now pass you over to Amar, who will talk to the paediatric.
Thanks, Kurum, and thanks, Claire, for that presentation. So I'm Amar Wahid, Paediatric Gastroenterology Consultant. I'm lead for Paediatric IBD in South Wales. Actually, up until yesterday, I was the lead for South Wales Paediatric Gastro Network. So I'll be talking a bit about paediatric IBD in South Wales, and also part of that is going to be the use of calprotectin in children, which has been a bit of a controversial topic in the past, but I'm really happy that we've managed to make progress with that, and now hopefully come up with something useful for you guys to use in primary care that will help us with diagnosing IBD in children. So the thing probably to start off with is pediatric IBD. They're not just small adults. There are some quite unique things about pediatric IBD that we do really need to be aware of, and I think it would be useful just to go through pediatric IBD just in general, just so that you guys know what sort of things to look out for in the community to help us with our diagnosis. So there is a significant proportion of IBD patients who are diagnosed in childhood and adolescence, about 25% according to some. and the majority present around pubertal growth spurt. So the median age has consistently for the last 10 years or more been around 13 years of age. But what we have seen changing quite dramatically is the incidence, and that's something that we looked at very closely through our centre in Cardiff. And I'll show you some data shortly just to show what that's actually translated into. A couple of the peculiarities for paediatric IBD, so the treatment strategy. So a lot of you may have come across liquid diet or exclusive enteral nutrition, which is one of the things that we try to use as much as we can, more than steroid induction. Also, the whole management of children with IBD or young people with IBD is really going into adolescent medicine, and everything that involves in terms of the psychology and the stage of life that they're at, and making sure that we're providing holistic care. So the way that we've tried to do that is to set up quite a wide MDT. So we have specialist nurse, we have a dietitian as part of our team, also access to psychology, a pharmacist, and we have regular regional meetings, outreach clinics to each of the health boards, and a weekly MDT meeting where people can bring difficult cases from each of the health boards and we can talk them through. So we do try to provide a holistic care in that adolescent setting for what can be really quite a complex and multifaceted condition. This is just a graphic from a paper that we published in conjunction with Oxford, Bristol and Southampton. We put all our data together in terms of incidence of paediatric IBD, going all the way back to 2013 through to 2022. So the picture on your far left, that's with the lighter blue. So that's looking at the incidence back in 2013. And then if you go across the top four and then the bottom four and then the image on the far right, you'll see just as the incidence increases, the color gets darker. So I think it's quite clear to see across all of the Southwest, inflammatory bowel disease in children the incidence has increased significantly. And probably the most stark way to probably present that is if we think back to 2017, which is around the time that I started in Cardiff, we had 17 new diagnoses made through Cardiff, just 17, and last year we were up to over 60. So almost quadruple the incidence. Not exactly sure why that is. Definitely the disease itself is becoming, it's increasing its natural incidence, but also I think we are getting better at looking for the condition, and definitely part of this, I would say, is more appropriate and actually more use of calprotectin. And so again, I really welcome the progress that we've made in this area. I thought it would be useful just to go through a case that's kind of goes across different time periods since 2019, which reflect really the landscape of paediatric IBD over the last few years and how it's evolved and how it's changed and what that might mean for primary care practitioners and what sort of things you might be looking for, what you might want to focus on when you're thinking about inflammatory bowel disease in children. So again, quite typically, this chap was 13 years old when he first presented. Rugby player. He initially went to see his GP with weight loss and abdominal pain, and was referred in to see a paediatrician. Before the referral made it to paediatrics, he was in A&E. So on the 15th of May, he attended A&E. And looking back at his A&E discharge letter, it says significant weight loss in inverted commas eating problem, and he was told to go and wait for his outpatient appointment. He did eventually then see a general paediatrician on the 28th of May, by which time he'd lost a significant amount of weight. So he went from 75 kg, kind of burly rugby player, down to 50 kg, and that happened over a couple of months. and he was admitted then from the paediatric clinic, and referred to us in paediatric gastro as an inpatient, and that took us into June. We did some initial investigations. He had blood tests that showed raised inflammatory markers, low albumin, anemia, raised platelets, and the calprotection, which was then checked for the first time, was above 1,250. So he very rapidly went on to have a colonoscopy on the emergency list, and he's found to have granulomas through his TIs, colon and rectum, all in keeping with the diagnosis of ileocolonic Crohn's disease. So I think that case really kind of probably sums up where we were in 2019, and why I think it would be really helpful if we can implement the calprotection pathway that we're suggesting. Is it could have been that when he was first seen, maybe a couple of months before he was admitted to hospital, we could have had that calprotectin, perhaps not lost so much weight, and then been seen directly by a paediatric gastroenterologist and had his colonoscopy and diagnosed a lot earlier. I think the other thing we would hope also, like through things like this webinar, is if we can increase the awareness of paediatric IBD and just really put it out there that children can get inflammatory bowel disease, and we should really try and make an effort, just even if we're thinking about conditions, then much more likely that we'll pick them up. So we'd hope that increasing the awareness of inflammatory bowel disease in children with the calprotectin pathway might help to increase our pickup rate for the condition. So again, it begs a test who to test. Claire obviously went through a lot of things about the different age groups and who to look for, things that are particular to children. So we would recommend that it's only done in children over the age of 6 years. We've got quite good data, which I'll show you shortly as well, just looking at what normal values for children, and really anything under 4, definitely, and then up to 6. If there's a suspicion of very early onset inflammatory bowel disease, which again can happen, it's extremely rare, that really needs a referral directly to one of us, to say that, you know, that's what you're considering. But again, those patients will be extremely unwell. Usually they're not thriving. They'll have terrible perianal disease, for example, and they're just a very sick, rare cohort of young children who unfortunately have that condition. But what we're talking about is in children over the age of 6 years old, who generally will have similar calprotectin levels in the healthy population compared to adults. I've just put on the right in that box just what the comment that will come up if it's requested for anyone younger than that age, really saying that if you are thinking about inflammatory bowel disease in children, then that needs to be requested by a paediatric specialist for that particular group. Again, like Claire said, we want the symptoms to have been going on for at least 4 weeks. And I think with children, the two things that we really want to make sure that we've ruled out is constipation and infection. So constipation, both of those things in children can give you a falsely raised calprotectin. Infection, I think, is the obvious one, and if you've got loose stool for any amount of time, then it makes sense, of course, to send off a stool test looking for infection to rule that out. Constipation can sometimes be a difficult one, and I think we need to really understand how children can present with constipation, and often it will be with loose stool, not just your typical straining and going red in the face. Actually, they can often present with overflow soiling or even soft stool constipation, where they've got a backup of stool, stretched colon that's able to hold on to a lot more, and then they're just getting, they could be opening the bowels 3 or 4 times a day, but still they've got a very loaded colon. So I think that's the sort of thing that just needs really careful history taking to make sure it's not that. So what is normal? This is a really good paper from 2020, plotting a nomogram of healthy children aged 4 to 16, and it really just very nicely illustrates the normal ranges for calprotectin in children of different ages. So it goes, the picture on the left is the nomogram. So you can see in the top row is the age of the child, and then the first line in the middle is the 95th percentile of fecal calprotectin, and then the bottom line is the 50th percentile. And you can see really after the age of 4, you're looking at very similar figures to adults. So when you, especially if you're looking up into the teenage years, the 95th percentile being 79, 69, and then 64, and then the 50th percentile being, really quite low. And then on the right is a scatter graph, just showing the same thing really. Again, just emphasizing that in children you can use calprotectin in a similar way to adults, with the caveat that you've ruled out those things that we mentioned earlier. So that's the pathway. Again, it's very small to be able to show clearly on there, but I understand the link is going to be sent out, so you should be able to see that. What I would say is just additional consideration in pediatrics is really just as you guys will remember from your pediatrics training, is the child well or unwell, and that's usually the first question that you want to ask whenever you assess a child. Really have to think about the diet and ask about that. If you've got a child who's very fussy or has a very beige diet, and they're coming with a distended abdomen and loose stool, it could very likely be that they're having overflow diarrhea from constipation. Have a think about the medication. Again, if they're on, if they've had recurrent upper respiratory tract infections and fevers, and they've had ibuprofen or other NSAIDs, that can affect the calprotectin level. But also think about things like growth, puberty. One of the ways that IBD can present in young people is delayed puberty. And if you've got unexplained poor growth in a child, one of the things to think about really is especially small bowel Crohn's disease, which can have quite a few symptoms apart from things like growth and puberty. Also, the impact that the symptoms might be having on their education, on their sport. Again, this our chap that we're talking about was a big rugby player who was not able to play his rugby anymore, and he'd lost a lot of weight. So I think that's a big thing to make sure we cover when we're seeing these patients. And then, of course, the one of the perks of pediatrics is they come with the appendages known as parents. So it's always good to try and keep them on board and understand where they're coming from, what their concerns are, and also have a low threshold. If there's a family history of inflammatory bowel disease, it does increase the chance that child may well have that, and so we'd have a low threshold for further investigation of anybody with a family history. I thought it was just useful, just with that same case, just to go briefly through what happened with him, because I think it just highlights the complexity of Crohn's disease in young people and how aggressive it can be. The fact that you're getting inflammatory bowel disease as a child already says that you have an aggressive phenotype. And these are the sort of things that can happen and did happen to this young lad over the following years. Initially, like we said, he was commenced on exclusive enteral nutrition as an inpatient. We did try it orally. He wasn't able to tolerate that, so we tried to give it through a nasogastric tube, and he was discharged from that hospital admission after 2 weeks, trying him on nasogastric tube feeding to see if that would induce remission. He was reviewed then in July and had shown some clinical response to EEN, but still blood's not quite normalized. But you'll see that I've made a note with no CRP or calprotectin. Again, this is one of the things that has changed now. We would definitely check repeat calprotectin to see that the induction treatment has been effective. And then he was started on azathioprine. Again, something that is not commonly done now. We would go really straight on to, for somebody like him, we would go straight to an anti-TNF. Seen again in August. By that time his nasogastric tube had been displaced, and at the time there was a vogue for trying partial enteral nutrition, which again has quickly gone out of vogue, and shown that actually it's not an effective way of managing Crohn's disease. And he carried on his azathioprine, but again, you'll see there's no repeat of calprotectin by then. And then when he's seen at the end of August, again in clinic, his inflammatory markers are still raised. He's clinically symptomatic, and his calprotectin is very significantly raised still. So really, if you look back, so this is the end of August, and probably for most of that year, he had active disease, which perhaps could have been picked up sooner, should have been treated quicker and more effectively, and by this stage, really, he should have had a normalized calprotectin. And I think what then happens later is probably because those things didn't happen, and we've got plenty of studies now showing that if you don't start early effective treatment, there is more chance of complications. He went on to vedolizumab, initially had a good clinical response. His diarrhea improved, less pain, better energy. Again, at that time, he was one of the first few patients we had in pediatrics starting vedolizumab. But then as he started that gut-specific monoclonal antibody, he started to develop rheumatology problems, musculoskeletal pain, stiffness, joint swelling. And again, it was thought, is this because of the vedolizumab, or is it because now his other inflammation is rearing its head? And he was advised by the rheumatology team to try and gradually improve his general fitness, to improve his musculoskeletal reserve, because actually all this time he had gone from being an active rugby player to somebody who was confined very much to his room. I should also add he was one of 10 siblings, and you could say a lot of the time it was he was having to manage a lot of his issues on his own. So again, putting all of that into the social context is really important for these young people. By the time he was seen in outpatient in September, he'd had a reversal of his wake-sleep pattern. His diet was completely off. He was on escalated dose of vedolizumab, and again, at that point, the calprotectin is significantly raised, and he went on a course of oral steroids then and restarted azathioprine. I hope that the kind of impression you're getting is reflective of, or read the amount of challenges that this young person had in managing his IBD all through these years. So remember, we're talking 2019 diagnosis. Now we're into December 2020. He's on 4 weekly vedolizumab. He's just had a course of steroids, and now he's developed perianal disease. With an MR pelvis, showing intersphincteric fistula with abscess and lots of inflammation in his low rectum. He had a colonoscopy, which was attended. A colonoscopy then, which showed deep ulcers throughout the colon and the ileocecal valve. So the vedolizumab is clearly not working. And we took him then to, at the time, Claire was part of the team, to the adult IBD MDT, who at the time advised against deep functioning and to try and carry on with the course of antibiotics and switch to another biologic, ustekinumab. EUA in June 2021 now, so still ongoing, showed severe fissuring perianal disease, with no deep fistula, but skin bridges that were divided at the time, and then the advice that the visiting adult surgeon who joined the pediatric surgeon for that procedure said we should consider a proctectomy if the colonic disease remains active. So really kind of at the really severe end of things. So you're talking about a chap now who's had Crohn's disease for 2 years. None of the regular treatments that you would usually try have worked. He's on to, at that time, what were novel treatments that didn't seem to be working. He had extraintestinal manifestations. He was nutritionally deplete, and he had musculoskeletal pain and perianal disease. So really a very severe case. Thankfully, he was in around this stage. He was coming up to 16, so he was brought into the transition clinics, which you have with the adult team. And with time, the ustekinumab seems to have helped improve his symptoms. His perianal disease did resolve. and then he had a surveillance colonoscopy before going over to the adult team, which was macroscopically normal, and that calprotectin level for the first time in a long time had normalized. So in terms of pediatrics, we got there in the end. Not sure with somebody with such aggressive disease, how long will it last? And what could we have done better? I think looking back, there's probably a few things at different levels in terms of earlier diagnosis, early effective treatment, more close monitoring. And I think all of those things are things that we've learned from and also are backed up by the IBD standards. And hopefully the calprotectin pathway that's been developed will help us to meet that more effectively as well. I did actually, when I was preparing this presentation, look up what's happening with this guy. Unfortunately, he's had again a relapse of his disease, and he's moved on to another biologic now, risankizumab, which hopefully will help to get him back into remission. But again, just highlights why it's so important we pick up these patients early, think about inflammatory bowel disease, and really give them the appropriate screening and testing that they need. So I'm just going to finish just with a couple of things that the high and mighty say. So NICE, October 2013, just confirmed for us, I think what we really knew but specified for children, that fecal calprotectin is recommended as an option to support clinicians with a differential diagnosis of IBD or non-IBD in children with suspected IBD who have been referred for special assessment if we have appropriate quality assurance processes and locally agreed care pathways are in place for the testing, which is thankfully what this implementation network is providing. And then specific to, again, to pediatrics, is the European and the North American guidelines, which in 2021 again state the use of fecal calprotectin testing in pediatric disorders in their position paper. That firstly, that you shouldn't just rely on the number itself, but put that into the wider clinical context of the child, and then also that in preterm infants younger than 1, so again saying that the very young children will have a raised calprotectin as a normal finding, so that we shouldn't be using it to check for inflammation in that age group. And then they say actually in children older than 4 years of age, the cutoff values of 50 as in adults can be used, although healthy children may have calprotectin levels up to 100 or even higher. And I think what we've developed covers all of that. So in summary, it is really important that we pick up inflammatory bowel disease early in children. Calprotectin is a really important test, and it's really useful when we use it appropriately. Please rule out constipation and infection, and think about the wider context of the child when assessing them, and look out for extraintestinal manifestations. And that's me done. Thank you.
Thank you, Amal. That was a really useful presentation. So we'd like to welcome any questions, if anybody has any, to pop them into the chat bar.